Picture two trauma patients arriving in the resuscitation bay simultaneously. Both monitors show dangerously low mean arterial pressures, and both hearts are struggling to move blood. But those identical numbers mask a critical difference in what is happening inside their bodies. Identifying hypovolemic shock is straightforward. The signs of poor perfusion are obvious. But shock and active hemorrhage are different clinical realities. A patient in shock may have already stopped bleeding, while a patient who is actively bleeding may not yet be in shock. If you try to correct the shock state of a patient who is still bleeding by aggressively restoring end organ perfusion, you are walking into a dangerous trap. Pushing volume to normalize their blood pressure will not stop the internal leak. This table shows the traditional classification system used to estimate blood loss based on heart rates and pressures. While historically standard, extreme individual variations in age, baseline medications, and body mass scramble these neat columns in practice, rendering it useless in a live trauma scenario. Prioritizing a normal blood pressure reading before achieving surgical hemostasis does not stabilize the patient. By accelerating their physiological decline, it converts a standard rescue attempt into a lethal intervention. Since static metrics fail to reveal active, concealed bleeding, the modern standard relies on a dynamic assessment. We evaluate exactly how a patient's blood pressure responds to a targeted volume infusion. In a responder profile, a bolus transfusion produces a solid, sustained improvement in blood pressure. The tank was low, but the leak is plugged. For a transient responder, an infusion spike creates a temporary rise before steadily sloping downward, indicating ongoing hemorrhage. In the non-responder profile, the spike produces absolutely no lift. The pressure flatlines because active bleeding aggressively outpaces the administered fluid. Relying on this dynamic assessment forces a critical shift in perspective. It stops clinicians from blindly reacting to a low pressure reading and provides immediate proof that they must locate and physically control the bleed. When we open a patient to find that bleed, we are racing against a biological clock. Severe tissue trauma triggers an immediate biochemical cascade within minutes of the initial injury. Before any medical interventions even begin, up to 25% of major trauma patients develop acute traumatic coagulopathy, or ATC. This is a rapid endogenous failure of the blood's ability to clot. Tissue trauma instantly triggers systemic hyperfibrinolysis, dissolving the structural links that form clots, while simultaneously causing severe platelet dysfunction and depleting fibrinogen levels. The onset of ATC is devastating. Patients who develop this endogenous coagulopathy face a four-fold increase in mortality. Because a severe trauma patient arrives at the bay already biochemically compromised, applying standard volume-heavy resuscitation protocols acts as a physiological trap. Standard clinical interventions take the baseline coagulopathy of ATC and directly convert it into a much more complex and frequently fatal condition, trauma-induced coagulopathy, or TIC. This spiral maps TIC's fatal loop. First, pumping clear fluids dilutes coagulation factors. Second, cold fluids and open body cavities cause rapid, severe hypothermia, inhibiting protease function. Finally, systemic hypoperfusion drives severe metabolic acidosis, completing the downward spiral. At this stage, severe acidosis and hypothermia completely inhibit coagulation proteases. The mechanical components of the clot simply shear apart and fail to interlock. By reflexively pushing fluids to fix a low blood pressure reading, the medical team directly destroys the body's remaining ability to form a clot. This guarantees physiological exhaustion and ultimately death. To stop this iatrogenic spiral, modern trauma care relies on damage control resuscitation, or DCR. This is a strict physiological holding pattern designed exclusively for actively bleeding patients. DCR rests on four pillars. The first is rapid, minimal surgical intervention. The operation is focused solely on stopping the hemorrhage and controlling sepsis. All definitive anatomical reconstructions are explicitly delayed until the patient is stable. The second pillar is permissive hypotension. Clinicians stabilize blood pressure at roughly 50 millimeters of mercury, maintaining perfusion without popping fragile clots. The third pillar prevents dilution, replacing volume using a strict 1-to-1 ratio of red blood cells to plasma. The fourth pillar requires aggressively treating existing coagulation deficits. Tranexamic acid is administered as early as possible to halt hyperfibrinolysis, followed by targeted blood component concentrates like cryoprecipitate or platelets. Damage control resuscitation is not meant to make the patient's numbers look normal. It deliberately holds them on the brink of shock to preserve the fragile biochemical machinery required for hemostasis. But this holding pattern is temporary. The critical pivot in trauma care comes the moment surgical hemostasis is verified. At that exact point, the counterintuitive rules of DCR must be immediately abandoned. The clinical objective flips instantly. The priority is no longer preserving coagulation capacity, but restoring end organ perfusion. Monitored parameters shift accordingly. We move away from coagulation assays like ROTEM and TEG, focusing tightly on strict perfusion metrics, base excess, lactate, and mixed venous oxygen saturation. With the physical bleed secured, the team can return to standard critical care logic. Adequate fluids and pressors are finally administered to establish normal preload and afterload. Mastering major trauma resuscitation requires recognizing that attempting to fix shock during an active bleed is a fatal error. Survival depends entirely on sequencing the rescue. You arrest the hemorrhage first, and you rescue the organ second.